Is it working?
Yeah.
Okay, good. All right, so today we start the pelvis and perineum. And so we'll just go over some overview points. This part of your chapter, quite honestly, is a little bit scattered, so we'll bounce around a little bit. I rearrange things to kind of group common topics together a little bit better. So we'll just kind of course through that. So we've seen this figure before, but what I want to point out, not so much the border between the abdominal cavity and the pelvic cavity, but the fact that we have two definitions that are used for the pelvis. The true or lesser pelvis is what we've been learning. That's the anatomically correct definition of the pelvis, from the sacral promontory to the superior edge of the pubic symphysis. But I can't say that word today. More commonly amongst the lay people, there we go. Often the pelvis is considered to extend all the way up to the top of the iliac crest, so up to here. So anatomically, that's not really correct, but often when you are talking with patients, they might be referring to something in the pelvis that's actually above what we would consider the pelvis. So just to make sure that you're aware of that. And they call this the false or greater pelvis. Ouch. All right, so then major structures of the pelvic cavity should be super easy. Urinary system, or at least what we haven't studied already, so the urinary bladder and the urethra, the lower parts of the ureters as well. And just remember, as far as naming, it is the urinary bladder because we have other bladders in the system. Make sure that you are specific with that name. We also have the rectum, the anal canal, and the anal aperture. Though really the anal canal and anal aperture technically are in the perineum, as well as most of the part of the urethra, but we're not going to be too picky about the separations between these two areas, unless it's a structure that's solely in one or the other. And then obviously most of the reproductive structures, so in the female, obviously the uterus, vagina, ovaries, fallopian tubes, all that stuff we'll get into. Okay, for the male, again, the rectum, anal canal, anal aperture, urinary system, and then their reproductive system. So, wow. Seminal vesicles, ductus deferens, prostate, ejaculatory duct. Those are the actual parts within the pelvic cavity, and then the rest, the penis and the rest are outside of that area, the actual pelvic cavity. Excuse me, my stuff in my throat. Yuck. Okay. So when we talk about the pelvic bone, we're just going to mention this really quickly, then actually go into talking about the bone. So a lot of the common, the genital structures that are, let's see, try saying this again. Wow, words are not coming today. The erectile genital structures of both male and female are anchored to the pelvic bone. So you can see here the roots of the external genitalia here, coming up to the erectile tissue for the female, that is the clitoris. Oh gosh, I'm really tired of this. Okay, and then for the male, we also see similar structures, the root of the penis, and then coming off of that, the body of the penis. And you see the common coloration between the two. This is indicative of common developmental origin. So early on in the fetus, you have general genitalia that start developing, and it's not until later in development when the sex hormones start circulating through the fetus that you get differentiating into the female reproductive structures and the male reproductive structures. Why are these attached or anchored to the pelvic bone? Well, again, these are the erectile tissues. And so since there's movement when the organ becomes engorged with blood during an erection, there's movement and it needs to have a solid anchor in order to not tear tissue. So it's especially important in the male, obviously. Excuse me. Okay. So we've talked about this before, but just go over it again briefly. The structures of the pelvic inlet. Remember, it's a circular opening here, or roughly circular opening, at least for females. In males, it's a little bit differently shaped, as we'll talk about later, probably tomorrow, or not tomorrow, Friday. Bordered by the sacral promontory, the ala of the sacrum, parts of the ilium, and the superior part of the pubic symphysis. And we'll go into some more detail next class period. Okay, on the other side, we have the pelvic outlet. So we flip the pelvis over, look at it from the inferior angle. We have the pelvic outlet. And so that goes from the tip of the coccyx here, along this ligament here, which is the sacrotuberous ligament, which connects the sacrum to the ischial tuberosity. And that will be important for several of the apertures we have. And that forms the posterior lateral part of the pelvic outlet. The anterior lateral is formed by the ischiopubic ramus, so this bone right here. And then finally, the inferior portion of the pubic symphysis completes the whole thing. So that is the pelvic outlet. Excuse me. Okay, so those are two major apertures. We've got coming in the top, going at the bottom. We've also got some other apertures along the sides and more posterior, or more anterior rather, to the pelvic outlet. We'll just point those out. We have the obturator foramen here on either side of the pubic symphysis. So this is the articulating facet of the pubic symphysis there. And then we have the greater and lesser sciatic foramina. So they're separated by the sacrospinous ligament. And this ligament goes from the sacrum, as its name implies, to the iliac spine. Or the ischial spine, sorry. That's the iliac spine. Ischial spine. Okay. So here. Okay, so this ligament here separates those two cavities. I think it's time to go back to the doctor. Excuse me. So several structures pass in and out of those. We'll learn that as we go along. Sorry?
Can you please go back?
Yep. There you go.
And can you slow down a little bit?
Sure.
I feel
Am I
like
going
I'm
faster?
Yeah.
I can't even tell I'm going faster. Feels like I'm in slow motion today, which is probably why I'm speeding up a little bit. Okay. Tell me when you're ready to keep going. Everybody set? Okay. All right, so here's just another view of all those foramina. So we've got this big old arrow here for the pelvic inlet. Here we can see the obturator foramen, so also called the obturator canal. Above that sacrospinous ligament, we have the greater sciatic foramen here. And then the lesser sciatic foramen below that ligament there. And then here is the pelvic outlet, kind of hiding behind that pubic symphysis. And we'll get to know all of the structures that move in and out of those foramina very well. Okay. A couple another view of it. So with extra muscles in place, We also have a small gap between the pubic symphysis and the perineal membrane, which we'll talk about in a minute. Allows for another area for structures to come out of the pelvic cavity proper. And then here, just another view of how the greater and lesser sciatic foramina, so they're kind of right in line with these ligaments here. So this is the sacrotuberous ligament. We cut it away, we can see the sacrospinous ligament underneath it here. And so we've got the lesser sciatic foramen here, and then underneath this sacrospinous ligament, it is the greater sciatic foramen. So again, getting that three-dimensional structure sorted out. That makes sense?
No.
Okay. So here's our ligaments. This is the bottom, the pelvic outlet here, right? Sacrotuberous ligament. Underneath that, if we cut underneath it, we have a hole here, right? And that space between that ligament and the sacrospinous ligament is the lesser sciatic foramen. So let's go back to here. Look at it. See, right here. So we're looking straight up this way. Okay? And then if we cut the sacrospinous ligament, we would then see this structure here that opens that is the anterior border of the greater sciatic foramen. Does that help a little bit more? Sort of, kind of?
So the sacrospinous ligament is under the sacrotuberous ligament?
Well, we're looking from the inferior aspect, so
Okay,
yeah. So it's technically it's superior to
superior
it.
to it.
But yes, in our view, first we're going to come across the sacrotuberous ligament, then we're going to come across the sacrospinous ligament, kind of both in line. Okay? And the space between the two ligaments is the lesser sciatic foramen. And then if we cut the sacrospinous ligament, then the space between that and the pelvic bone would be the greater sciatic foramen. Does that help? That make sense now?
Maybe.
Yep.
So the arrows
Uh-huh.
on the right side of this?
Yeah, so those arrows just show the paths of some of the structures that go in and out of this. So one of them we'll talk about is the pudendal nerve. And that one goes in and out of the pelvic cavity, and then it goes back in, and then it goes out. And it's like, it can't decide where it wants to be, but it kind of loops between all those ligaments. Yeah. No, it's just showing movement of structures. Yeah. Okay. Does this?
So between the two ligaments is the lesser?
Yes, is the lesser sciatic
So where's the
foramen.
greater then?
The greater's above the sacrospinous ligament. Okay, so.
The greater.
Yeah, so let's see.
The greater's.
Yes.
I guess.
Right.
Foramen.
So,
That's that thing.
let's turn this bone around here. Okay, so the tuberous ligament from here, the sacrum, down to the ischial tuberosity, right? Okay, so that space there. Sacrospinous is from here, in the sacrum again to the ischial spine, right here. So we've got this space here between the two, where my finger is. That is where the lesser sciatic foramen is, right? Then above here, between this top of this bone here, bottom of this bone, and the what's this called? The ischial spine. That is the greater sciatic foramen. Does that help? Okay, everybody see that? Okay. So again, you gotta struggle with the 3D orientation thing, so you need to be able to think about it from all different angles, especially with the pelvis, because a lot of your pelvic exams are going to be from the inferior aspect, right? We can't just look down from the top and see what's going on, like in the images, right? as nice as that would be. Okay, so then there's a couple of muscles that I want to talk about in relation to them. So then first, let's just identify the ligaments. This ligament is the sacrotibial, and this one is the sacrospinous. Okay, in the greater sciatic foramen here, we have the piriformis muscle. So it inserts here on the sacrum. It actually extends out to attach to the femur. And this is relevant not only because it gets really sore when I exercise. Oh my gosh! But the sciatic nerve can run either under. Let's change colors for that. So you can either run under, over, or through the piriformis muscle. This would be the sciatic nerve. Okay. Those that have was it 2% of the population that has the sciatic nerve run over the piriformis muscle, so superior to the piriformis muscle, will often have problems with intragluteal injections damaging the sciatic nerve because it's so much higher. So one reason why they tend to actually inject in the lateral thigh right now instead of the intragluteal region is because of this percentage of the population that have the sciatic nerve up so high. Okay. Then we have the obturator internus muscle that almost completely occludes the obturator foramen. So remember the obturator foramen was kind of right there. We've just got this little tiny canal here, whoops, that I just obliterated with my writing. There, obturator canal. That allows the obturator nerve and vessels to run out of the pelvic cavity. Okay. Okay, we good? All right, moving on. Okay, so then, like the superior part of the abdominal cavity having the diaphragm, we have a pelvic diaphragm, which is a layer of muscles that kind of defines the floor of the pelvic cavity. This is a really odd diagram trying to depict them. But at this point, next class period we'll go into it more deeply, but at this point, know that it's a sheet of muscles that is domed, well, inverse of domed, whatever that is, because I can't think of the word right now, that forms part of the pelvic floor. So that would be the pelvic diaphragm. It's predominantly consists of, Okay.
What about the dome? Yeah.
It's an inverted dome, so I couldn't think of the word. A cup type structure? I don't know. Just don't worry about that too much. That's just my inability to describe things today. So no worries about that. Just know it's muscles that form the bottom part of the pelvic cavity. And the two main muscle groups are the coccygeus muscle here. Excuse me. And the levator ani muscle. And eventually we'll talk about all the rest of them that make up the levator ani muscle, but for now, just levator ani. Okay. So that's the pelvic diaphragm. Okay. The pelvic floor includes an additional structure, the perineal membrane here. And this is a fascial membrane, so it's a layer of fascia. Excuse me. That divides the perineum into two pouches. The deep pouch you see here, which is between the pelvic floor and the perineal membrane, and then a superficial pouch, which is everything outside of the deep pouch. Okay. Let's not obliterate what I want to talk about next.
Both of those are part of the pelvic floor?
Yes. In this, we have several apertures. So we have the anal aperture. The urethral orifice. And then in females, the vaginal orifice as well. Okay. Any questions? Are we good to go on? Okay.
What angle is this view from right here?
This angle is kind of, yeah, it's kind of lateral, sort of kind of lateral, but not quite completely lateral. So kind of anterolateral, about the level of the sacrum. So, getting this bones out here again, it would be kind of this angle right here.
Where's the bow?
What's so funny?
Anal spot makes it easier.
Oh. Yes, that does help. Okay.
Good job, Justin. Good job.
All right. Next question. What is the extent of the peritoneum within the pelvic cavity? So remember, we have portions of the peritoneal cavity that continue on into the pelvic cavity. So here in the male, we have it extending all the way down through over the bladder. We have a little recess here between the bladder and the rectum, comes up over the rectum, another recess here. In the female, obviously, we would also have the uterus sticking out here. So it does go down and extend into the pelvic cavity. Okay. And we have several structures that are continuous between the abdominal cavity and the pelvic cavity. You guys should be able to name those off. What would you think? So structures that are continuous between the abdominal cavity and the pelvic cavity. Sorry? Well, we have a branch off the common iliacs, the internal iliacs. Yeah. Then we've got this here. This is the rectum. Yep. The bladder pokes its head out of the pelvic inlet a little bit, as does the fundus of the uterus. During pregnancy, obviously, it expands quite a bit into the abdominal cavity as well. And then, obviously, the ureters as well. Okay, so just keeping in mind that there's a lot of continuous structures between those. And also, we've got the scarpus fascia that becomes the part of the pelvic fascia, perineal fascia. Okay, so at the floor of the pelvis again, we have the anal and urogenital triangles. So they're two triangles divided by a line that runs from the two ischial tuberosities. The urogenital triangle is anterior of that line. You can see here, kind of triangular shape. Contains the roots of the external genitalia and the urethral and vaginal orifices, and is where the perineal membrane is.
Can you repeat that?
Yep. So, urogenital triangle is anterior of the line between the ischial tuberosities, contains the external, there we go, genitalia. Wow. I don't even know I should try to write that. Genitalia roots, and the urethral and vaginal orifices, and includes the perineal membrane. The anal triangle is at posterior to that line between the ischial tuberosities. It's nice and simple, contains the anal aperture, as well as associated muscles of the pelvic floor. Okay, we good? All right, so here's just the male version. Here's our urogenital triangle, again, containing the roots of the external genitalia, the penis, and the anal triangle containing the anal aperture. All right, so what pelvic structures are close to the ureters? Why does it matter? So we talked a little bit about this the last lecture. So the ureters are fragile, the blood supply to them is fragile. So I just want to point out on this one, the uterine artery in females actually loops over the ureter. And remember, we have a branch of arterial supply to the ureters from the gonadal arteries, concluding the uterine artery. Why does this matter? Well, during hysterectomy, you're working around in there. You have to ligate the uterine artery, so you must do it downstream of where the blood flow to the ureter comes off the uterine artery. Otherwise, you will have ischemia and death in that part of the ureter. You also be super careful when you're removing the uterus to make sure not damage the ureter as well. In the male, it's the ductus deferens that runs close to the ureter, a little further down, closer to where it connects with the bladder. And this is not as much of an importance with most surgeries with males. So typically, if they're messing around with the ductus deferens, or the vas deferens is its other name, it's a vasectomy, meaning they're clipping the vas deferens to enforce sterility in the male. And so that's usually done in the scrotum, so you don't have to worry about it affecting the ureter. But if you're doing any intra-abdominal surgeries, again, you have to be paying attention to the ureter and its blood supply. Okay. Okay, also in the male, some positional information that's of clinical relevance. The prostate gland is located just anterior to the rectum, and that makes it possible to do a digital rectal exam, so using the hand to palpate the prostate from the rectum, making it a fairly easy way to assess for enlargement of the prostate or for prostate cancer. So enlargement of the prostate is a normal process, happens in aging males, but it has no link to development of cancer. However, it can start to shut off, what's the word I'm looking for? The urethra, so they have reduced ability to void their bladder. Cancer, on the other hand, during palpation will have variations in the shape, so it will no longer be smooth and round. It'll be irregularly shaped, and also it'll have irregularities in density, so some hard spots, some soft spots within the prostate gland. So those are the things that people are looking for when doing a prostate exam. Okay. So dermatomes of the perineum. So unlike the thorax and the abdomen, they're not nice and lined out straight for us. And this is because as the limb is developing, it doesn't just grow straight out. It actually twists during development to generate the correct positioning of bones in the mature animal. So we have L1 here from kind of the lower part of the abdomen, and then we go back to L2 over here on the posterior part of the thigh, L3 up at the anterior part of the thigh, and then we get into the sacral dermatomyotomes. So S2 going down the thigh, S3, 4, and 5 in the urogenital region, anal region. Just note that S4 extends more anteriorly in the male than it does in the female, a little bit. And it's a little more irregularly shaped for them. Okay, so be aware of the differences, and for this one, you should know where each one of these dermatomes are, because it's so different. Okay, so some important neural components of the pelvis. So this is the pudendal nerve, and the reason we bring it up today is because it's the one that can't decide whether it wants to be in the pelvis cavity or out of the pelvic cavity. So if it starts here from the sacral nerves, and it exits the pelvic cavity through the greater sciatic foramen, comes back in the lesser sciatic foramen, and then finally heads back out through the pelvic outlet. So it kind of just wanders about in there. Yep. So the pudendal nerve exits the pelvic cavity through the greater sciatic foramen, re-enters the pelvic cavity in the lesser sciatic foramen, and then re-exits it through the pelvic outlet. So it just kind of wanders its way around in there. Why? I haven't a clue. There's really no good reason as far as I'm concerned. But it does what it does, because it wants to, I guess.
Re-exits through what?
Re-exits through the pelvic outlet. So the only thing I can think of is that as the animal is developing, it is traveling along gradients of growth hormones that just happen to cause it to meander out that way. Not knowing the development of the pelvis that well, I don't know what those would be for sure, but that would be my guess. Okay, another important neural component we need to consider is the prostatic plexus. So here, this mesh network around the prostate is the prostatic plexus. And why is it important? Well, during prostate removal, if the prostate has become enlarged enough to cut off urine flow or has become cancerous, they go in and remove it. And this plexus supplies the erectile tissue, so it contains the nerves to the erectile tissue of the penis. So often after a prostate removal, you have erectile dysfunction because those nerves are no longer getting to the erectile tissue, so they cannot stimulate the engorgement and erection of the penis. So ED is a problem. Okay. Next question, what is the perineal body? So perineal body here is kind of a poorly defined region, but it's kind of just an area where a lot of the muscles in the pelvic floor converge. So a lot of them come, and it serves as an attachment point for those muscles. Excuse me. See what else I was supposed to say about it. Can't remember at the moment. Yeah, that's this point. Sometimes during childbirth, if the birth canal is not large enough and there seems to be some tearing of the vaginal orifice, they'll sometimes cut into the perineal body to enlarge the birth canal instead of allowing the vagina to tear. Now, actually, there's evidence that actually heals more slowly if they excise the perineal body. So they actually just allow the tear to happen naturally. It seems to repair faster and better. That is the word I'm looking for. Okay. And then final question that we'll talk about today is the difference between the male and female urethra. Obviously, the female, it's a very short, straight urethra. And what the relevance of that is, wow, brain not working today. Sorry. Higher bladder infection rate. So once you get a UTI, urinary tract infection, has less road to travel before it reaches the bladder. So females have a higher frequency of bladder infection. And then in males, where it's longer, because it's got to go all through the penis. It also has several bends. It's just more of an obstacle for the urinary tract infection to get up into the bladder. However, males don't have it all rosy. With a catheter insertion, males are more likely to have structural damage due to catheter insertion as they're getting around the bends in the urethra here and here. And it's just a longer structure to push the catheter through. Okay, so 40 minutes, is that good for you guys? Give you enough time to get to your foot clinic, so enjoy, have a good time, taking care of people's feet.
Well, you're welcome to join.
I have a lot to do. It would be very interesting though. And we'll see you in lab tomorrow.
Are we having lab after the
Quiz?
Yeah.
Yep, like we did last time.